Hi, Gypsies! Today we will be having Russ, the Chief Clinical Officer from Gifted Healthcare, go live and discuss LTAC, which, if you're not familiar with that, is long-term acute care. So Russ launched the Gifted LTAC division, so he has a lot of great information and experience to share with us today. So feel free to ask him questions in the comment section. He'll be happy to answer them and try to get to all of them as much as he can. So I'm going to go ahead and bring Russ up. Hello.
Hey, how are you?
I'm good. How are you?
Great.
Good. Well, I'm going to drop off. Thank you so much for coming on today and talking about this. We have a lot of people interested in it. So I'm going to let you get to it.
Thank you. Hey, Gypsy nurses, thanks for having me today. I appreciate the opportunity to talk to you guys and you taking some time out to hang out with me. I've actually been to a Gypsy convention before down in New Orleans. Probably won't talk about that today, but I had a good time for sure. Tell you a little bit about me. My name is Russell Johnson. I've been a nurse for over 20 years. Started my career in MICU in 1999. Got a lot of great experience there. I just couldn't live off $11.40 an hour, so things were going to have to change. Got my year in and started traveling a little bit. Did some sales, worked with some up-and-coming companies on some platelet grafting, but they wanted me to move to Chicago, which I wasn't ready to do that. So I hooked up with a couple of my friends, and we started a plan that we had developed back when we were in nursing school, and we started our own little agency. Created my R&D Medical Staffing in 2001. Our first contract was a LTAC facility. So that's where I really started in the LTAC world. Worked it in every realm of nursing. So we started hitting kind of the economic downfall in 2009. And that's where we kind of really turned over and started doing more travel nursing associated with LTACs. Ran that for about 15 years. In 2015, I decided that, I was tired of running the business and I wanted something better. So I joined Gifted Healthcare and I was able to become their Chief Clinical Officer for the LTAC division. I've been happy with that ever since. Love the company and I love doing what I'm doing, working with hospitals and nurses. So over the last 20 years, I've been in every position in LTAC I can think of, and I've gotten to learn a lot about it and how it works. So with that being said, let's go into some LTAC history. In late 1990s, we were seeing a lot of these patients stay in ICUs for a long period of time. Medicare and Medicaid actually came up with this plan to open these facilities in order to cut costs. That's, they were trying to save money. You can imagine the cost of a ICU patient on a daily charges for staying there for 45 days. It's just astronomical. So they started paying these companies to develop, and they pay them off a DRG. So that basically they give them a certain amount of money per diagnosis. So respiratory failure is a great one in there, and that's the one we look for. But you've probably heard of a lot of these companies over your years of nursing, and have some offers being offered to you to go work at them. But some of these companies are called Select Medical, Kindred Healthcare. Those are probably the two largest LTAC companies in the country. You also have Vibra, Post Acute Medical, Louisiana Healthcare, Cornerstone, Promise, Continue Care, Life Care, and Landmark facilities. And they're scattered all throughout the country. And so each of them kind of had the same goal, but they're all still a little bit different. So we'll talk more about that as we go through, but just kind of wanted to give you a short little brief history on the LTACs. It's basically there to cut costs for insurance companies and try to save them money. We'll go into some of the LTAC settings. There are a couple different kinds of LTACs. You have a hospital inside of a hospital facility, or you sometimes have standalone facilities. Hospital inside of a hospital is basically a unit that the hospital has leased from the host facility. Some of these hospitals can range from 20-bed facilities all the way up to over 100 beds. So they can be small or large. The ones inside of a hospital, they use a lot of the resources of the hospital. They'll sub out their labs, their radiology, some of their surgeries, everything else will come from that host facility that they contract with. So, but they have full hospital services inside of these. They have RNs, CNAs, RTs, PTs, OTs, speech, pharmacy, dietary, discharge planning, everything that a big hospital will have, these small hospitals will have as well. A lot of the administration in these settings will be the CEO, the CNO. They'll have a quality director. They'll have an HR director. They'll have a dietary person. And they have all sorts of therapies as well, too, to get these patients in line. A lot of these facilities are small. Like I said, there'll be 20 patients on these units. You'll have daily communication with the CEO, the CNO, and it helps develop some of those relationships that can carry you on to further jobs down the line. But the LTAC has just been special to me. I've actually had several family members in some of these LTAC facilities. But my goal today is to kind of paint a picture for you guys to see if LTAC nursing could be the right fit for you. It's not for everyone. It is hard work. And, you know, I just want to be able to give you some insight the next time that you talk to your recruiters and your organizations to see if they offer you an LTAC, that you'll have some understanding of kind of what you're going into and kind of what it takes to do the job in an LTAC. Some of these LTAC patients, a lot of misconception between the LTAC patient is they get mixed up with long-term care patients, and they are totally different ends of the spectrum. The acute is in the long-term acute name for a reason. These patients are acutely ill. We are looking for patients to come out of the ICU quickly. We'd like them before they get 7 days if they know there's going to be a long-term stay needed associated with that. When I was in the ICU, we had a small PCU unit in the back of our unit. It was about 6 beds, but it carried our long-term vent-dependent patients back there. Those patients back then would have been better off in an LTAC environment. They probably would have gotten more therapy and probably a little bit stronger weaning process to try to make that stay. A lot of these patients in these LTACs, you know, they're critically ill. They're medically complex patients. They're going to have a lot of diagnoses like respiratory failure, COPD, emphysema, sepsis. They'll be compounded with end-stage renal disease. They'll have wounds. They'll be diabetics. A lot of infections in these places. We do keep these patients longer term, so they are a little more susceptible to infections just because all their lines that they utilize to take care of them. We do give a lot of antibiotics. So you'll see infections in these facilities like MRSA, BRE, and of course, you know, we'll have antibiotic associated C. diff as well at times. So these patients, you know, they're there. And the length of stay for these facilities is going to be on average of 25 days. That's how they get reimbursed through Medicare and insurance companies. If they have short stays, and they have to make sure that their longer stay people add up to that 25-day period. But some of the devices that you'll see in these facilities, you'll see PICs, CVLs, vents, trachs. Some of the patients will come in intubated, and they'll have ET tubes still, PEG tubes, NG tubes, chest tubes, wound vacs, and they have actually started doing some LVADs. Some of the units will have art lines in their high observation units, but you know, don't see a whole lot of those. But again, back to the settings, some of these facilities will just have like a small unit on the floor where they can cut out 6 beds to have them hardwired to where they do have ICU capabilities in those beds. And that's kind of what we're seeing more of is these medically complex patients. We're trying to get them to LTACs faster and free up these ICUs for new patients coming in. But more of this patients that we'll see and some of the procedures that we'll do bronchs. We'll trach patients at the bedside. We'll have PEG tubes placed at the bedside. chest tube placements, wound debridements. I've done lumbar punctures, CDL, and PICC placements. All those are usually done at the bedside at these facilities to kind of cut down on cost. Some of the bigger ones, they will go to interventional radiology, and some of those procedures will be done there inside the hospital, inside of a hospital. I'll kind of give you some of my personal stories. I've had a brother that's been in an LTAC recently to kind of give you a picture of one of the patients that you might have. My brother, he actually got hit on his Harley, actually going to work. His foot's probably still in the motor of it, but they degloved his foot, and he ended up having to have his leg amputated below the knee. He had to have a major rod put in his femur, lost his shoulder. I ended up getting 20 units of blood and had 3 small strokes at the age of 30. He was in ICU for quite some time. When I seen him, he was maxed out on Levophed, and we were able to get him weaned down. Took him a while to get off the ventilator. Got him to the ortho floor, but they just weren't giving him the therapy that he needed. He couldn't quite go to rehab just because of he couldn't do the number of hours of therapy that they required at rehab. So we were able to get him into an LTAC, and I pushed for that. He wasn't on a ventilator, didn't have anything like that. He needed a lot of therapy. His speech was slurred. So they worked on his speech at the LTAC. They worked on his strengthening at the LTAC. And of course, they kept giving him antibiotics, and he was still needing blood. So that was one of the patients that kind of paints a picture that's not as critical, but he still meets criteria to go to an LTAC facility. But he made a full recovery for the most part. He still has complications, but his speech improved, his strengthening improved, where he was able to go to rehab within 30 days. And after rehab, he was actually walking out of rehab. So without that LTAC environment in between his hospital acute stay and the rehab, then it would have been really a struggle for us to take him home and strengthen him on our own to get him back to the rehab. So that's one case scenario to where it really supported us to have the LTAC in between those other settings. Another one is my father-in-law. My father-in-law, he actually was a patient of mine. Actually talked to, he had lung cancer. It was isolated in one lobe. We were able to have surgery to take that lobe out. Really struggled getting him off the vent. He had been a smoker for a while. He stayed in ICU about 7 days. I asked the physician if he would follow him back up to the LTAC and get him up there. We could do more therapy with him, get him up in the chair more frequently, and start working on getting him weaned off the ventilator. He was able to come up there to us. We did wean him off the ventilator within 2 weeks. Stayed on trach collar for a while. One that we actually trached at the bedside. We really was aggressive with his weaning protocols. We were able to get him off the vent, worked on strengthening. He was one that did need some drips at times. He was on a little neo drip at first in order to maintain some of his pressures. And then actually went into uncontrolled AFib. So we ended up starting on a Cardizem drip later on in his stay. Once he started working a little bit harder, his heart got a little bit out of rhythm. But that LTAC environment actually pushed him to get stronger to where we could send him to rehab for another 3 weeks. And we were able to get him home functioning pretty well. And I actually got a few more years of life for him. And that's 2 different scenarios of LTACs that one could be more critical. One could have a little more ICU skill set that you would need. And the other one is probably just more of a stronger tele-med-surg nurse that could work on that patient as well. These environments are very diverse. I hope that those 2 examples can show you that these patients can go anywhere from a rehab top level patient all the way up to a critical care patient. So that's what we're kind of looking for nurses for these facilities. We want nurses that have, of course, a little bit of an ICU skill set. Well, of course, the first nurse we're looking for is an LTAC nurse. If you've worked in an LTAC nurse, you know the environment. You really understand kind of what we're doing in an LTAC environment. but we're also looking for nurses that don't have any LTAC experience to build into LTAC. We want some nurses that have a timing mechanism. This is what I call it, a timing mechanism, and also a skill set. So if we can find a combination of the two, the timing mechanism, anybody with med-surg, tele, rehab, but they also could have some ICU experience, step-down experience, and sometimes a little ER experience will come in there. I know a lot of the ER nurses hold some of the ICU level patients in ER holding until they're able to open up a bed for those patients. So they kind of have an understanding of what we're looking for as far as the critical care aspect of it. We just want to make sure that they both have the timing mechanism plus the skill set. But some of the most important factors in becoming an LTAC nurse is confidence. You have to be confident in your skill set. You have to be a team player. These units are small. You will work together with several other nurses. We'll talk about some of the ratios here in a minute, but dependable. You can imagine some of these hospitals that are 40 beds, and that's their staff for 30. So we're able to support with travel nurses or local nurses in there to fill up that facility. And if somebody calls in or is not dependable, they continue to call in. They probably won't be there very long, just because it puts so much pressure on the other team. They don't have other resources that they can pull from, like another floor that they can just pull a nurse down to support that unit. So either the CNO has to come out, support, and help as a charge nurse, and the charge nurse may have to take patients as well. But dependability is huge. A great attitude goes a long way in these facilities. Like I said, they're small. For me, working in an LTAC environment, it was able to give me a lot of personal growth. I told you I came out of an ICU unit. This was my first contract in an LTAC facility. I was drowning. I had no timing mechanism to take care of that many patients. I had 5 patients. I think 2 were ventilated. One of those was on a drip as well. I had a guy that would walk and talk down the hall, and I had 2 other, I think I had a paraplegic in one room with just wounds, and then another little lady that had been in for sepsis getting antibiotics. But me as an ICU nurse, I wanted to see all those patients, and I usually see them through glass with monitors I can read. These were behind closed doors, and we were working off not the best equipment at the time. So I was really drowning, trying to keep my eyes on my patients and do everything I could at the bedside. But there's no way I could chart on 5 patients at the time when I first came into LTAC nursing. So it took me a while to grasp the concept of that timing mechanism. But once I did, I really fell in love with it. I became very passionate about it. Once I was that aspect of where I was doing that, they started moving us in some charge roles, and that really, I loved it. I mean, I was able to help other nurses that had been in the same situation I was in, or maybe they had some more just strong tele nurses out there that I could teach and educate on the aspects of some critical thinking skills. And so I became more of a resource and an educator while I was doing that charge role. And that really made me just love to do that, because people were looking up to me. I was the one that would run the codes. I got to do all that stuff just from being in the ICU and learning all that aspect of nursing, and then bringing it back into the LTAC environment. I've really enjoyed doing the education piece with some of those nurses, teaching them how to titrate drips, working on trach care and suctioning, and seeing different things in labs and showing them abnormal lab values and how that can correlate with not only their pulmonary functions, but also their renal functions. And, I love the teaching aspect of that. So I really kept continuing to strive through it. And kind of worked my way up. I was a floor nurse for a long time. With these facilities being small, a lot of times there's a lot of turnover, and you can kind of move your way up through there. Before long, I was doing charge capabilities, like I said before. I got in great with this organization that I was working with at this time, and they started asking me to travel a little bit to go to some hospitals that they needed support at. So, I met more upper level management, and, then they would start asking for me, and then it would carry on to where, they were asking me to send support to those facilities. So the resources that you get from working in these, it's not somebody that's in a tower over there just crunching numbers for the hospital. They still have to do that as well, but they are hands-on with their facility and really want to support their patients the best. One thing, if you guys do get offers for LTAC environments then from your recruiters or anybody like that that's sending you job offers for those, I would please ask that you interview. Make sure that these people are can kind of tell you about the culture of the facility. They're all different. If she's got 100% agency staff in there, sometimes it's not the best facility. It's not the best culture in there, and you have to watch out for that. You can ask her about the acuity. How sick are these patients? Are you running ratios of 5 to 1, 6 to 1? We see that. Are you running ratios of 3 to 1 with more higher acuity patients that you need more high level ICU skills? So you can see by asking a lot of questions if you think you'll fit into that facility or not. A lot of these facilities are different. Some of them run a lot higher acuity than others. They do try to generally staff on acuity, but of course, that doesn't always happen. We have call-ins. We have to take extra loads at times. Puts a little more stress on us to get all our care done. But we usually see LTAC ratios usually about 4 to 5 to 1. And I'm not going to say you're not going to have 6 or 7 one day. No, especially at nights, you could. Especially if they're lower acuity patients that you might just be hanging antibiotics on, or some of them are getting ready to discharge. But you could also see ratios that you're going to have 2 patients to 1. I've done one-on-one care where I have multiple drips hanging, still intubated, requiring restraints, some sedatives, things like that. So I've worked one-on-one all the way up to 7-on-1. And it's just kind of what it is in an LTAC and kind of the patients that you'll be receiving. Some of the medications that you might see in an LTAC, as far as the drips, a lot of the pressors, definitely Levofed, it's usually in there. You'll run some of that. We do some other drips like Cardizem. Of course, therapeutic drips. We'll have insulin drips. We'll have heparin drips, all those things. So, drips aren't always common, but you could have some at different times. Definitely a lot of ventilator support. We like the ventilators coming to LTACs. We'd love to see our wean ratios increase. So you will have vents, you will have trachs, but of course, like I said, you have RTs in these houses 24/7. If you have any questions with the ventilator or any settings on it that you might need to see change, then they'll take care of all that. They'll do all your gases for you. The main thing you need to make sure is you keep that airway. I mean, you have to do support for your RTs by keeping their airways clear. But again, some of the other stuff that you'll see in an LTAC, it's not any different than you'll see in an acute care hospital. And that's why we're really pushing to make sure we shine the light on the acute, because this is still real nursing. It's not long-term care. A lot of your long-term care patients are going to be patients that are they're still ill and they're still elderly, but they're not needing acute support at that time. So we want to keep on the level of acute care. Some of your requirements for this, the main thing is you got your BLS and your ACLS. That we looked at some of the facilities wanting to go to some of the staff having TNCC. They really haven't done all that just yet, but I could see some other charge nurses and stuff having that down the line just to be a resource for everyone. And usually your charge nurses are a good resource. If you're not the strongest ICU nurse, but you do take an assignment there, these charge nurses shouldn't have any problem supporting you and helping you with any questions that you have. If they do, you could definitely talk to your agency and let them know you're not getting the right support. I make a lot of those calls for us. I talk to a lot of the CNOs and just make sure that our nurses are the right fit for their facility. So, yeah, just if you're confident, have your ACLS, BLS, you're not afraid to talk to people. There's people there on a daily basis that can help you with anything that you come across in an LTAC. Does anybody have any questions so far? All right. I talked about a lot of the devices that you'll see. Definitely talked about a lot of the procedures that you'll do. Kind of what's in everybody's mind right now is probably the COVID and how COVID is affecting these LTACs. When COVID first started coming around, we've seen a drastic increase in patients in the LTAC environment. It wasn't COVID patients. What the acute care hospitals were doing, they were expecting to have such a ramp up of patients coming in, they were trying to empty. So we've seen a lot of clean patients come into our LTACs out of the acute care setting just to open them up, keep those patients clean and get them out of that COVID environment that was coming into the acute setting. We did see some incentive rate with that just because of the competition. I mean, everybody was looking for nurses at the time. The LTACs were having the patients come in, so they were having to increase their pay rates as well to generate some more resources for them. And we did see that. COVID became more of a standard thing and started slowing down a little bit. And so you're still seeing the LTAC patients, their census stay up and elevated. So there was a lot of jobs coming into these LTACs just because they were. But that's not saying all of them were able to stay clean. You know, we did see some COVID come into some of these LTACs. And of course, they turned those into COVID units, and they were trying to keep their other patients moved to a different facility or just take COVID patients in those LTACs that were already contaminated. Now we're also seeing the surge of the COVID recovery patients. Have already tested negative twice after having COVID positive test. And so now we're starting to see the COVID recovery patients come into these facilities, which in turn is still keeping our censuses up and jobs available. A lot of the rates did kind of stay back at a normal rate there for the last 6 weeks. But of late, we're seeing a resurgence of COVID around the country, definitely in different locations now. And so we are starting to see some incentivized rates come back up to take on these COVID recovery patients. A lot of these LTACs, they are squared away on their PPE. They are following all the guidelines that everyone else is following. I don't know how many calls I've taken. It's because everybody thinks that their hospital's a one-off and they're not doing things right. But everyone is following the CDC guidelines. You are wearing the N95s. You are gowning, you're gloving, you're doing everything else that you normally would on these patients. And they're just trying to decrease the load on the hospitals because now we're resurging back up again. So we don't want these COVID recovery patients to stay in these acute care hospitals anymore when they don't need to be. So we're going to take them into our units. We're going to take care of them, get them strengthening their endurance back up to where it needs to be, and then get them back to their normal life. And that's kind of where we're at with COVID. I haven't heard of a whole lot of our LTACs just blowing up with it. They will have, a few of them that'll slip in there or they will test positive. But for the most part, they are staying clean as they can be in order to accommodate these acute care facilities and make sure that they have the room and the resources to take care of these COVID patients that are coming into their facilities now. But LTAC, again, like I said, I've been passionate about LTAC for ever since probably 2 years into it. I've met a lot of great people in the LTAC environment. There's a lot of great nurses in LTAC. Just because, you have to kind of juggle a lot of the different disease processes that these patients have. It's not only will it be respiratory failure, but it's going to be renal insufficiency. I mean, you have to kind of judge everything, even down to, what kind of tube feeding they may be getting, or what kind of antibiotics. I mean, people are always on that. All these hospitals have interdisciplinary teams that meet once a week and work on discharge planning for these patients. The goal of an LTAC is to get them to a lower level of care, just like it would be in the ICU. And when I was in the ICU, my goal was to get that patient out of that unit onto the floor. In the LTAC, it's the same way. It just takes a little bit longer. And, the thing I guess that's the thing I like about it is I get to follow that patient through. So even if you do a 13-week contract, at an LTAC facility, I've had patients roll in that were intubated, on pressors, and just wasn't sure they were going to make it. So, we worked on them, we got them weaned, we got them off the pressors. And, before they get discharged, you might be able to go out there and dance with that same lady you rolled in near death, dance with her in her walker, and it's lots up. I love the geriatric population. A lot of LTAC is geriatric patients. And, it's just these people have lived a great life. They've been through a lot of stuff, and I think they need good care here at the end of life. And sometimes these LTAC facilities are decision-making units. Sometimes it could be these patients' last-ditch effort to make it, or they don't. And so that's another part of it that I really enjoy is probably some of the end-of-life care associated with LTAC nursing. Strong faith that I have, I'm able to share that, or, I've prayed over patients before with family members, and, it's something special to me. And I think it's a big piece of this piece of nursing is that you can comfort these patients, when they're going through end of life. And so you do have a hospice aspect of this nursing as well too. But, I always love it. I've done a lot of special things with some of my patients. I've actually taken some of them to funerals before that I'd be off work and they needed somebody to go, and they were on a trach collar still at home, or, I've actually transported one of the patients after she got discharged to closer to her home in Texas from Arkansas. And it's things like that I've gotten to do just because I've gotten to know some of these families so much better. These patients in an LTAC setting, they're very vulnerable. They're complex patients for one, but they've been in the hospital so much that, it's stressing on their family, it's stressing on their spouse, just to comfort them enough to let them know that we're taking care of them. They trust me enough, maybe to go home and sleep for a while. If I'm working nights and I can take care of them and be with them at night, they can call me anytime. It's just little things like that that's different sometimes in an LTAC environment than some of the other environments that we work in. But I hope I painted a decent picture for you. I would love to answer some more of your questions if you have any. But if you ever come across an LTAC job and that your recruiter's pushing to you, I wish you would think about it. If you can meet those skill sets to where you have a little bit of ICU level knowledge, and you can also have a timing mechanism of maybe some med surg or tele, take a look at it. But interview for it, ask the questions that you need to make yourself comfortable going into that environment, and see if that could be a good fit for you. I feel like LTACs for the longest time have gotten a bad rap, and a lot of it is because of the patient loads that they take. A lot of times we don't have the best families. They're frustrated. They're tired. We have probably higher infection rates because we have Foley's in longer. We have CVLs in longer. But we've really tried over the last few years to cut down those, not getting reimbursed for those anymore. So everybody's making a push to get those Foley's out quicker, get those lines out faster, but we still have to medicate and treat these patients and monitor. So sometimes they stay a little bit longer. We end up getting more infections. I think that's just part of it. It's not what we want to see. It's not what we have, how LTAC nurses want to be trained as we work on that unit. But I think it's really made a big change over the last 20 years that it really has a positive impact. I've seen some tremendous outcomes come out of these LTAC facilities, and some of the relationships that I've made with not only patients and families have lasted years and years. So I just don't throw it out just because it's an LTAC position. wish you would take a look at it, think about it, and interview and see if it's a fit for you. That's about my piece. I would love to answer some questions if you have any, but I hope I painted a decent picture of what an LTAC environment looks like for you, some of the things that you'll see in it, and kind of how it works. But I'm always available. I'm sure I have some type of a section on there that you guys can get in touch with me if I can answer any questions for you. I would love to. I talk to nurses all the time about their fit in this environment, if it would be good for them or not. I'll tell you straight up, I don't want to lead you into a bad situation.
Well, thank you, Russ. If anybody has any questions, you can, even if this is over, we're not live, you can still ask questions in the comments, and then they'll be happy to answer your questions. And then we'll get Russ's information in the comment section as well. So if you want to get a hold of him or anything like that, you can ask him some questions. But thank you so much. There's a lot of great information you gave, and I can't believe how much personal experience you've had. I'm sure it's really hard, but it's really nice to have that knowledge, and then have someone that close to you be able to, you can speak for it and everything.
Yeah,
so
it's great.
All right.
Thanks for having me.
Yeah,
thanks.
All right. Have a good day, everybody.
Thank you.